Hello everyone, welcome to my video channel. Today I am going to talk regarding below knee amputation BKA or transtibial amputation. The question that was always asked during my exam. So number 1, I will cover regarding what is the indication for below knee amputation. Number 2, regarding the usage of tourniquet in below knee amputation. Number 3, the usage of prophylactic antibiotic in below knee amputation. Number 4, what is the ideal length for BKA stump? Number 5 and 6 usually question regarding a surgical viva. Number 7, how do you prevent neuroma formation? Number 9, would you use radivac and why? Number 10, the choice between open versus closing the below knee amputation wound. Number 11, dressing for below knee amputation stump. Number 13, postoperative management for patient post below knee amputation. Number 13, regarding what is the energy expenditure. Number 16, what is the qualitative factors that you would use for elective below knee amputation. The disclaimer is the same in all my videos. Thank you. Now let's begin. As an introduction, what is below knee amputation? BKA. It is a transtibial amputation that involves in removing the foot, ankle joint, distal tibia and fibula with related soft tissue structures. In general, below knee amputation is preferred over and above knee amputation, aka because below knee amputation has better rehabilitation and functional outcomes, especially in terms of energy expenditure. I will discuss more regarding this topic later in the video. Number 1, what is the indication for below knee amputation? Again, an amputation is the surgical removal of a part of the body, example foot, wrist, etc. etc. The indication for below knee amputation involve the 4 Ds: dead, dying, dangerous, and damn nuisance. The first D that I will cover is dead, whereby patient has a severe infection of the limb. If the source of infection is not removed, patient has higher risk of dying. The second D is dying, whereby the limb is gangrenous, as often as a result of peripheral arterial disease. The third D is dangerous. If there is a serious trauma to the limb, example a crush injury or a blast wound, if the affected limb is not removed, it will lead to a severe complication such as reperfusion injury or reperfusion syndrome. Another dangerous indication is a recurrent tumors with false smelling and bleeding ulceration. The final indication for below knee amputation is damn nuisance, whereby the limb is deformed and has limited movement and function, or the affected limb is causing a severe pain that affects the patient activity daily living, example in a neuropathic lower limb secondary to a nerve problem, example in a CRPS or complex regional pain syndrome, especially in type 2. For number 2, would you use tourniquet for below knee amputation procedure? If yes, why? And if no, why? Well, yes, I would use tourniquet to reduce the blood loss during amputation, and it will facilitate identification of anatomical structures. And no, I would not use tourniquet when the limb is gangrene, that indicate patient has a peripheral vascular disease or in a malignancy case. When using tourniquet, the duration of the ischemia should limit to 2 hours. That is to reduce the risk of reperfusion injury. For number 3, would you give prophylactic antibiotic prior to below knee amputation? The conclusion by J. McIntosh et al. In 2009, I quote, "The review highlighted that the clinicians agree about the need for antibiotic prophylaxis in patients undergoing major limb amputations and vascular construction. In addition, many patients have active sepsis, where prophylactic antibiotics will reduce the rate of stump infection after major limb amputation. For question number 4, what is the ideal length for BKA stump, below knee amputation stump? Any idea? Well, actually, the optimal length is 2.5 cm for every 30 cm of patient's height. Stump length is measured from medial joint line to the tibial cut. Example, if the patient height is 150 cm, the optimal length is around 12.5 cm, whereby 5 times 2.5 cm. For question number 5 and 6, it is almost a common question. Number 5, how do you do below knee amputation? Again, I emphasize, is among the common surgical viva topics that is frequently asked during the final exam. I will do another video that covers the surgical approach to below knee amputation. And question number 6, how do you cut the tibia and fibula bone? Also, I will cover in the surgical approach to below knee amputation. For question number 7, how do you cut the nerve to prevent neuroma formation? When a nerve is cut, the proximal end will exhibit an axonal sprouting. This phenomenon potentially allows the proximal end to reconnect with the distal end. However, when the distal end is lost, example due to amputation, the severed nerve may form a neuroma. The formation of a neuroma is a benign process. However, it can become a painful problem when the neuroma is located in the scar tissue or an area of frequent contact or high pressure. Prevention of symptomatic neuroma can be employed during initial amputation for prevention of symptomatic neuromas or after amputation for treatment of painful neuromas. Among the methods include A. Traction neurectomy. It is a common technique in which tension is applied to the nerve prior to division. This results in proximal retraction of the nerve away from the distal sides that will subject to substantial pressure with prosthetic use. B. By burying the severed nerve into the nearby muscle or bone. C. By using a two severed nerve that are coapted to form a loop to achieve a central nerve union. D. Targeted muscle reinnervation. And E. Silicone capping of the proximal nerve ends. However, the risk involved is an adverse reaction to the silicone, infection, granuloma formation, and migration of the silicone cap. Okay, next, we are going to cover another question. Number 8, regarding myodesis versus myoplasty. Which one would you use? How to do it? The advantage and disadvantage of each method? Well, this question is partly covered in my previous video, Ideal Amputation Stump. Thank you. For number 9, would you use radivac and why? Routine or selective insertion of drains following below knee amputation is not uncommon. Study by Smith that et al. 2003, I quote, "There is no solid evidence regarding the dressing or drains used in the management of below knee amputation stump. Drains actually helps in obliterating the dead space, reduce the hematoma formation, and ultimately wound breakdown. Number 10. The choice between open versus closed below knee amputation wound. When do you decide to close or not to close the below knee amputation wound? When the primary closure is not feasible, amputation should be done in a staged manner. An initial open amputation is done to provide adequate drainage of infection. Indirectly, this will control the infection, eliminate the bacteremia, and provide a safer wound environment for a definitive amputation at a later date. In severe traumatic injury, it is heavily contaminated. Therefore, open amputation is preferred. Usually, the amputation is formed with plan as how it will eventually be shaped and closed. In a trauma case, there is an intermediate zone of tissue injury. This zone usually requires time to either recover or demarcate, and multiple secondary surgeries can be required before it becomes evident if the involved tissue is viable or whether it must be removed. Number 11. How you do dressing for a below knee amputation stump? There are two types of dressing that can be used. Depends on the surgeon's preference. It can be divided into A. Soft dressing or B. Rigid dressing. For soft dressing or compressive dressing, it helps in controlling the swelling. It minimizes the postoperative pain and promoting a stable limb volume. It is done by a sterile, compressible, and cover the wound beneath a layer of elastic bandage. Advantage of soft dressing: there is an ease of application and easier access to the wound. The disadvantage of soft dressing include complications that arise from poor wrapping of the residual limb and risk of joint contractures. For B. Rigid dressing, the amputation site is immobilized and the appropriate local pressure and elevation protocols are applied. The inflammatory response and edema associated with early healing is minimized. During the rigid dressing, there will be an infrequent dressing. This helps in wound healing process. Rigid dressing is done by using example POP, plaster of Paris, elastic plaster of Paris, thermoplastic materials. Dressing is applied at the end of the surgery and is changed within 5 to 14 days. In rigid dressing, a proper rigid cast protocol includes a therapeutic degree of terminal pressure while promoting a sterile, dry wound surface with no restriction to hinder circulation. Important that there are no proximal constriction should be applied to the dressing, and the dressing must be adequately suspended to maintain distal circulation. This is important to prevent falling away of cast. For number 12 question, what is the post-operative management for patient undergoing below knee amputation? The primary goals of post-surgical amputation management include uncomplicated wound healing, control of edema, control of post-operative pain, prevention of joint contracture, and rapid rehabilitation to optimal levels of activity. Before attempting a prosthetic fitting, the residual limb changes shape and volume. Muscle readapt, and the limb will mature. Time and maturation are necessary in order to avoid a painful mismatching between the shape of the residual limb and prosthesis socket. Number 13. What is the energy expenditure for A, 1 BKA, B, 1 AKA, C, 2 BKA? Any idea, guys and girls? Well, before I give the answer, let's ponder about this question. This is really important to decide later whether patient will be able to ambulate or not post-operatively. Well, the answer is ranking of metabolic demand. The percentage represent amount of increase of metabolic requirement compared to the baseline. For some amputation, a requirement is around 15%. Transtibial or below knee amputation for traumatic cause is around 25% average. For short below knee amputation, there will be a 40% increase of metabolic demand. For long BKA, 10% of metabolic requirement or demand. For vascular causes, the metabolic demand will increase around 40% post-surgery. For transfemoral above knee amputation, traumatic cause, there will be an increase of around 68% of the metabolic demand compared to the baseline. For vascular cause, there will be an 100% increase in metabolic requirement. For bilateral amputation or 2 below knee amputation, the metabolic requirement or demand will increase around 40% from the baseline. For number 14 question, tell me about prosthesis for below knee amputation. Well, this is another big topic that I need and will cover in another video. It includes the parts, the elements, etc. etc. So stay tuned. Number 15 question. What are the indications that can predict whether patient will be high risk for wound breakdown in below knee amputation? Please remember, local complication after amputation is the failure of the stump to heal. This is due to A. Result of a continued ischemia, B. Infection caused by wound contamination by pathogenic bacteria. There is a study by T. Richards et al. In 2005, and I quote, "There is evidence that 30 to 40% of the legs are already colonized with pathogenic bacteria prior to amputation." Another factor for failure of the stump to heal are due to C. Failure to define the appropriate level of amputation with respect to the remaining blood supply in the leg. D. Patient comorbidities, example diabetes mellitus, old age, smoking, etc. I already covered in my previous videos. The title of the video is Wound Healing, especially factors that affect the wound healing. For question number 16, what is the qualitative factors that you use for elective BKA? Well, I am quoting a study by DN et al. In 1998 and protocol approved by the Ottawa Hospital Rehabilitation Center Ethics Board. The qualitative factors used for an elective amputation include severe pain that affects the patient activity daily living, ADL, and patient's well-being. Poor function of the affected limb that patient wants to remove it, and patient is hopeful for the improved function after the removal of the affected limb by using a prosthesis. The less important factors include a lot of information, opinion from family or clinicians, and body image plays a less significant role. The number 17 question. Tell me about skew flam. Well, this is one of the technique for below knee amputation or transtibial amputation. I will cover regarding this topic in surgical approach topics. Okay, thank you. Phew, finally, we already reached at the end of our video. I hope you have learned something or gathered some information regarding below knee amputation or transtibial amputation. Till we meet again, see you and bye.